Knock myself right here. I don't really care what they have to say about it. I answered my question with your question. Hello. You're muted, Pat. You're muted on purpose. You don't want me to hear what you're saying.
No, you don't want to hear my voice. How you doing?
Good, good, good. Now, these PowerPoints, are these things I'm expected to share, or will people just follow
I will
along?
share them. I was gonna say, I will share them. If you'll give me the host, I will share the one that says straw man, but I don't know how many of those folks who are attending today were on our call on Friday. So I want to share, I want to make available the other slides to them that we used last Friday. And sometimes you'll get to know me about this stuff, Tiana. Sometimes I do it last minute because I keep on ruminating on things until I release them. So
Yeah, well, and sometimes I would think you're not getting the information because you just had a meeting that you've got to finalize everything.
you think?
Yeah, no, that's okay.
Yeah.
I just made you co-host, by the way.
Yeah, great. And when as we get our Prevent-A-Care formally announced, we will only use that platform for these PowerPoints. So that way I won't be creating all kinds of garbage. But until we do, what I don't like about the current RCPSO platform is you have to cut and paste things into it, and you can't just type things in. So that's reasons why I wanted them to create that platform for us.
Now, when you say platform, are you talking about the template, the PowerPoint template?
Template. Yeah.
Okay. All right.
Yeah.
Well, I've got some.
As things stabilize, we'll be able to, when we formally announce it. Here we go. Here comes Chris. Are you gonna let people in? You want me to?
I wanted to wait till our topic of conversation changed.
Okay. You think? All right. Yeah, now they're in. I know who this UCAN is. Oh, there she is.
Good morning, afternoon, whatever it is.
Hey, Joan. Joan, it's been 24 hours. I haven't seen you on screen.
I know. Well, I've been in my garden all day, so
Oh, lucky you.
Yep.
I've been on so many Zooms. I had to switch computers. My computer overheated.
Oh dear.
Hey, Terry. Chris Buck, aren't you tired of hearing my voice? You keep coming back to these webinars.
She's a glutton for punishment.
Yeah, either that or we need to talk to your boss. Oh, I see, she's there. You talk to your boss about giving you some more work to do. Uh-oh, is he frozen?
I don't think he's good. Oh, maybe now he's frozen.
Work.
Come on, Gary, give him more work to do.
Yep. Anytime he opens his mouth, more work.
Wait. I don't think that's what he was meaning by that sentence.
That's exactly what I meant.
Well, hey, Fatty, look at the time. I gotta go. It's nice seeing you.
I gotta go now, right?
No.
Nice. Tiana, do you have a kind of who's attending today? I see a whole bunch of folks from VFI. Are others coming, or is this going to be a VFI pilot?
Well, I don't have the RSVP list, but looking at the folks that it was sent to, VFI, there were a number of folks, but we also had folks from Allied, Devereaux, My Independence at Home, UCP Central PA, Accessibility. Yeah. So we might have a few more. I don't have.
Were you surprised yesterday when Janine said that they still have PAS?
Yeah, she said for a few more months. I don't know what that means.
I don't either. I don't either, so. Because this is our standing weekly meeting, isn't it? I think, so, monthly meeting, whatever. So that's why I was expecting a slightly bigger turnout, so. What do you guys think? Should we get started and get others to catch up when they do? I'm going to share my screen. That way I have something to follow through on. This is this discussion is up today to follow up on the conversation we had about 2 weeks ago, and then regarding the fact that we have an opportunity to present a proposal to PHW on the 22nd of the month, which is, it's moving really fast. We're a week away. The opportunity is to get a value-based payment pilot for the RCPSO ownership. And what I wanted, we discussed this, we provided for the group an overview of value-based opportunities that may exist. We did that presentation on Friday last week, and we had a number of folks participate in it. For those of you who did not, we have that session, was a 1 hour. You don't have to hear my voice forever. And we have some slides. Tiana will forward those slides to you, as well as the slides that I'm using right now after this session. And you also, I don't know if Tiana, if you have it available now, but we actually recorded that other conversation so that we can give you, if you want to listen to it, please feel free to do so. So our opportunity here to talk to PHW is, we wanted to make sure it's something that we can deliver and take credit for, but also to make it something that we can afford to do when considering what they will pay us, because they have to pay for this one. We're not gonna do it just because we like them, and how replicable it can be. A pilot, not intended to be a system-wide for everybody. And so any questions about that? I know there's a couple of folks who weren't with us in prior conversations. Are you comfortable with the reason why we're having this conversation for framework? Okay, great. So in order to make it something that we can actually do something with, as opposed to just pretend we're going to collect data, I propose that we identify with PHW consumers who have a high potential or high risk consumers, people who might have multiple morbidities, co-occurring conditions, and we can work with them on what those are. They may be congestive heart failure, diabetes, obesity, and so on, in addition to the physical as part of CHC, including folks with a high fall risk and folks who may have had a hospitalization in the past 6 months. And the reason I suggest we do it on a focused basis is that I believe that if we do a group of people that we pre-identify for tracking in this kind of a pilot, we would be able to actually begin tracking on day one and demonstrate activities rather quickly. What, first of all, I need input from this because you guys are going to say, this sounds good, let's go on, until your agency has to do work with it. So please help me out here. If you think that this is, or you want to add additional dimensions here, please do so, because I believe whatever we want on paper and let them negotiate with us. So rather, as I said, we do it on a focused basis. We do it with 200 to 500 consumers in the pilot. They would all obviously be PHW consumers. And we have an opportunity because we have two service coordination entities who are also RCPSO owners. And those are Service Coordination Unlimited and Pennsylvania Health and Health Management, VA Health Management. I've had conversations with both of them about potentially being involved in a pilot, and they were receptive to the idea. Obviously, they're not part of the conversation today because you guys need to give us feedback on it before we do anything. Does this core group of consumers, by making sure that we know that they have a possibility of having a higher utilization in the future, as well as knowing that we can keep eyes on them, but also that we can work with collaborative service coordination. I don't know whether we could do this as well, and just because I don't know, with an in-house agency, but I know that we could do it, or an in-house service coordination. But I feel pretty confident that working with Matt's team, as well as with Bailey and her crew, we can get this done. I'd like some input on this one, and dimensions you want to add to the way we define the population?
I think that's a good group to start thinking about. They're the ones that are closer to potentially costing the MCO more money. Another hospitalization, or falling again if they've fallen already, or an outcome that's related to not managing some of their health conditions as closely as it could be, with some processes in place to know about things and act on them quickly, which is the thing you need to do this. So just a thought about working with the SCs. I think that's a great idea to work, start with working with folks we know and would be cooperative in likely helping us do that and demonstrate that. But it might also be of some value to PHW if we some service coordinators that are their internal folks and learn from the experience, what can be improved, whether external or internal, to get better results. We heard over and over and over again at the MLTSS MAC meeting that people were not happy with the customer service they felt they got from the new service coordinator system when the MCOs took over. So this may be a way to help them learn what, you know, what they can do better so that that dynamic is improved. They all said they wanted to make it better.
Yeah. Now, for maybe the others know, I see Deb Vendetti also just joined us. Does PHW have any in-house service coordination for folks living in the community? I thought they were only contracting that out. And I wouldn't have any problem in working with folks like at Liberty Community Connections or Bridge for Independence, but I was thinking we would get more collaboration. So please, whether PHW is doing using only in-house folks or just contracting out.
All Abilities, Patty, subsidiary of Life Steps, does not have a contract currently with PHW. So to your point, that may be true. It may just be all in-house.
I'm gonna put Courtney on the spot because she works or because they are the ones that work the closest with the service coordinators on service authorizations. So I'm gonna ask them if they see anybody that isn't from an outside organization.
I'm muted.
Oh. Do we need to unmute?
Sorry, this is Jen. As far as I know, PHW does not have any internals. I believe everyone is contracted.
Yeah.
Oh, interesting.
I know ABI is their SC as well as Liberty Community Connections. But I
SC contracts with PHW too, I believe.
okay. Okay. Yeah, I mean, I suggested this only because I know we can get cooperation from these two rather than. But I have no objection to including others. Add and others.
I think this is Carrie, and I think I would rather hear the rest of the presentation to see what we're in for.
Okay. I'm not telling you, sorry.
Yeah.
No
before we
preview. That's
talk
why I
about-
didn't send you the slides.
Yeah, I didn't have a chance to look at all of them
Okay.
before this, and to see what we are going to try to
Okay.
do before we figure out how many service coordination agencies we want to try to work with.
Fair enough. Thank you.
Mhm.
So what I'm suggesting is, as we look at this, to only commit to things that we can deliver on. And to me, the three top things we can help with and deliver on is intervention, prevention, and reporting. Those are three things that we know we can take action as providers to get our DCWs attendants who are in the home with these consumers to actually report on some information for us so that we can step in and help identify consumers who may be having a decline in condition or who are having issues related to that could lead into a hospitalization room visit. And we can deliver on reporting. So those three to me are as I'll show you in a minute, are things that we can actually deliver on. What we cannot deliver on is to say, therefore, the consumers will never go to the hospital again, or that and you might even argue with me on prevention, because maybe we cannot commit to prevention because we cannot, control the consumer 24/7 in their actions. So control, as in control activities 24/7. So, but I believe we can take action in this proposal around intervention and reporting for sure. And prevention is the third key area that would the MCO avoid having to add more hours to the consumer schedule. Because remember that in this particular situation, because we're not trying to tap into the cost of the hospitalization, since that's really not what the CHC pays for, we're just saying to the MCO, we can work with you so that you can intervene before there is an incident, and therefore you can avoid having to increase the hours. Does that make sense? Should we take prevention out of our conversation? Okay.
Hard, simply because under CHC, it doesn't cost the consumer anything to go to the hospital versus go to their PCP when there is a brewing issue. So it's often easier for them to just, instead of wait for a doctor's appointment to come up, go straight to the ER, and then they get immediate attention. So prevention is a difficult one. Sorry, Chris, go ahead.
I'm sorry, Carrie, I thought you were done. No, I mean, I agree. I think it's inevitable. There's good variables that we don't deal with. So my gut is to not and maybe invite it when we can help it, because there's so many cards of that deck we don't hold when it comes to prevention.
Okay.
But yeah, I don't know. That's
all right. Any others? Because I'm happy to take prevention out. I mean, I want you guys to give me your honest assessment of this. I don't want to. There is no attention can be gone.
and maybe if we did something like an intervention's good, reporting, credential, and the rest of that looks solid. Maybe if we did something more like of a follow-up, like instead of using the word prevention, like I guess it could be tied into intervention, but if we could almost like some sort of like a crisis plan, if there's some sort of, something that's developed to assist in affecting it without saying preventing it, if that makes sense. So like we can help with education, with coaching them through, other things. Ultimately, they want them to go to their PCP. They want them to make those appointments. So if we had some language in there that we would be an active part of developing a strategy to strategize or something, instead of prevention, instead of saying what the outcome be, more what the elaborate on the intervention piece and not focus on one outcome we might not be able to cash.
Okay. Excellent point. Thank you. I'll add that into the final version. Reporting is one we can do. One of the things that, and it's not, the next one is credentialing. And I'll talk about reporting in a couple of seconds, but credentialing is one that all of you on this call know I'm a strong advocate of. but I don't know where we are in the process across the board. If we differentiate our agencies by having them be accredited by one of the deemed CMS bodies, then we'll be a cut above everybody. Is that something we want to discuss in this level of a proposal, or is this something that we want to defer to a future conversation?
I can tell you that our organization has not started credentialing, started it.
Okay. Deb, how about you guys?
We have begun to meet with the 3 accrediting bodies to align
Okay.
programs and services within the organization to see what programs and services can be accredited.
Okay.
You gave such good advice when interviewing with them. It's really important to find ones that align with
Mhm.
the organization and what the intention would be, because it's different. For example, if you're medical modeled versus non-medical modeled.
Yeah. Yeah, Joint Commission tends to be much more medical than SHAP or ACHC. That,
Correct.
and the cost.
And then some of the accrediting bodies, if you choose them, they accredit the entire organization. So anything within your organization that they have program and service that align, you're in for that program as well.
Right. So if you have a home modification or transportation or one of those other things that they cover, they can
Right. So
step into it too.
So we are pretty deep into the analysis, which I would recommend. It's not like, okay, let's pick this one. We've had a team that have been peeling away at that onion, listing all the services, talking, and then, reviewing the standards. The standards are several pages long, and just to review them and the communication back and forth, they're all 3 were very receptive and will help guide you along the way. But it's an investment and a big decision for an organization.
Okay.
So yes, we're pretty deep into that process. But my question would be, is there any of the MCOs, will they be writing that in their contract, that that's something they're going to be looking for, and or are they going to recommend that one over the other? And I think you had said before they are not.
There's nothing that's changed since we talked about it, Deb.
Right.
But just for the benefit of the others on this call, in other states where managed care organizations have an LTSS program, some of the, like for example, in New Jersey, the state decided up front, they said, we're going to give everybody 18 months to be credentialed. Have a nice day. And if you're not credentialed, you cannot be an MA provider. So in some states, that's what happened. But in long run states like Arizona, for example, over the years, only the credentialed agencies were contracted. So the ones who are, it became a self-fulfilling prophecy rather than and eventually it snuck into the contracts. So it wasn't like an immediate, you must be credentialed in order to be contracted. But it ended up making a difference.
Patty, I can tell you that while I completely agree with you on the credentialing, we just don't have the resources at our agency right now, meaning people wise,
Mhm.
to lend to credentialing. Chasing service authorizations
Mm.
on a daily basis just to get paid.
Okay, so from what I'm hearing is, the two agencies who are on this call are not credentialed today, and so I think for purposes of this proposal, we should leave credentialing out of what we put on the table to PHW. Would you agree?
I would agree. I don't see, yeah,
Like
I don't,
that?
I don't credentialing can, depending on who you talk to, some say, oh, 9 months, but we know it's really gonna be longer than that. I don't
It's
see
gonna
us
be
being
about a
able,
year to a year and a half.
yeah, I don't see us being able to do that in the next year
Okay.
and complete the process. Start it maybe, but complete it, I don't think so.
So maybe Tiana, as part of our, since you're keeping notes on this meeting, please, maybe as part of our work group here, once we get through this immediate conversation, we should bring back an agenda for what kind of technical assistance we can provide through RCPSO to help the agencies who are either making the decision or who have not even started the process. Because ultimately, I believe that it's something. Okay. All right. So what else we can deliver is we can deliver eyes on the consumer. Nobody can actually report on the consumer's health and well-being as well as our own direct care workers and attendants. We can also provide training for our DCWs so that they are actually able to recognize and working with, come up with trainings that are appropriate for the DCW so they can help identify changing conditions and ways to report on them. We can work directly with the service coordination agencies, whether they are PHW, whether they are RCPSO owners or not. And then finally, we can have RCPSO do some consolidated reporting on their own results, but then we can do a meta reporting on all of the participating consumers so that there's a benchmark that can be utilized in reporting to the results of this pilot. And the reason I bring that up again is in a conversation that we had for another conversation that Joan and I were involved in yesterday. One of the responsibilities of the is to provide evidence of whatever they test and pilot back to the state as part of their contract. So we can, if we're working with only RCPSO agencies, we can actually gather the data and roll it up and be able to provide them the reporting that meets their contract requirements. Are there other things that you guys think we can truly deliver on as a group or to this kind of a conversation? Well, I know we all have to be careful what we commit to. So we will take out from this slide the first statement that they are all accredited. But we can report on HEDIS data and we can provide a real effective incident management prevention training so that and intervention. So we would develop a specific processes that would demonstrate early interventions with these consumers, so that as certain indicators come up, we report them and provide the appropriate referral to either the programs, education for consumers, or the ones that the service coordinator actually provide. The goal is to reduce the hospitalization and hopefully reduce the post-acute higher plans. We talked about identifying the consumers. We would provide them the training that's appropriate. We would provide weekly reporting, the service. But also, we need to talk about the potential for nurse intervention. And because some of these consumers may need some meds, education, or they may need a potential somebody who would say they should get a PERS system and so on. And I would like some thought from you guys on how we would provide the nurse intervention, whether we need PHW to say, this is a referral and therefore we get a nurse intervention, or is that something that we would seek out and get a nurse to do as part of the compensation that
I think the one thing that comes to mind, and Fatty, and I could be totally off base with this, but with nurse intervention, you know, for home care versus home health care, we would have to be somewhat cautious. Department of Health would look unfavorably on us for doing certain nurse, you know, tasks under a home care licensure. So we'd have to be cautious on that piece.
Yep. But what if that was, you know, what if we had a contracted home health entity that would be the one that comes in and provides that intervention, that nurse intervention? Because I don't think that we should do it ourselves. But we should be able to reach out for it and get it, rather than wait to go get prior authorization. Is a prior authorization process.
When you're talking about nurse intervention, Fatty, what exactly are you referring to? Are you talking about a nurse going in and tending to their needs, or a nurse assessing the need and making the recommendation as to whether or not they should go to the ER to have something looked at, or go to their primary care?
I'm thinking the latter.
Okay.
The latter, not tend to their needs, but to intervene to determine what the appropriate level of intervention should be.
Okay,
or possibly even education.
Right, our nurses already do that whenever we get a call from a direct care worker and they aren't, they're concerned about something. Our nurses will already advise them to say, you know, go to this is something that, you know, can be managed, or keep your eye on it, whatever. Our nurses are already doing that. And oftentimes, by the time the direct care worker gets it to us, the recommendation is go to the ER.
So that's part of the DCW training, Carrie, is to say, can we train the DCW to raise the flag sooner, so that before it's an ER event, eaten in 3 days, or the consumer has not taken their meds in a number of days, that they would actually reach out and try to get some kind of an intervention. Because today they don't report on those kinds of events. Do they?
It depends on the direct care worker.
Yeah, you're right. Yeah. But
Some
couldn't
are
we
very,
train-
yeah, some are
could we-
very really adhere to they really adhere to the consumer as the boss, and if they don't want to do it, then they don't want to do it. I'm here to do what they tell me to do.
What do you think, Deb?
I would, they have the right to choose what they want, right? I was just looking up, we, we track the incidences. I think it's all in the training to have the direct care worker to be our eyes and ears, to track, we all track hospitalizations, but I think we should focus on prevention in some manner. But I think that can only the cooperation and the training of the direct care worker, hands down.
Right, and if you had, I'm just thinking, we have about 12 agencies in our mix for RCPSO. And if let's say there were 20 consumers in your agency who were actually going to be part of this pilot, would training with those 20 individuals associated with high-risk consumers to actually make a difference, or is that too much strain on getting those 20 people up to speed?
Just to close the loop, when we're talking about accreditation, I mean, we would have to keep that on there, because that is a standard. That is something they're looking for. Develop baseline information system to preserve participants' health and safety and reduce hospitalization. I mean, to not put that on there would be remiss. I mean, I think it needs to be on there, but how you get that baseline information and preserve participants' health and safety and reduce hospitalization, it only can happen through the training. So I think it needs to stay on there. And I think in a pilot, we can look at a post, baseline, and then tracking if those hospitalizations are reduced. And that would be our goal, right? To reduce the hospitalization in that high-risk consumer pilot program.
Well, we would track the hospitalizations, but I think for the benefit of the CHC MCO specifically, what we would be able to say is, because we intervened, we were able to avoid a higher utilization of PAS services. I mean, this is a counterintuitive thing for us to say, that we're going to make the number of hours not go up, because that's really the only thing that will pay for this program. Because if we avoid the hospitalization, Gateway gets paid. So, but where PHW benefits is that if there is no hospitalization, then the plan doesn't go up, because consumers' plan tend to go up and they have a hard time bringing them back down. So that's really maybe that needs to be much more clearly stated in the document, that's, those were the things that we would really commit to delivering on.
Patty, the other thing is pretty much the majority of the people that Voices is serving would fall into the population that we're targeting.
Okay, so, but for purposes of this pilot, if we picked a small group of those. Would that be to monitor the results? Is that possible?
And would we pick them or would PA Health and Wellness pick them?
I don't know. Tell me what you think.
Chris, Jen, Courtney, what are your thoughts? I think they're all in this thing with each other on their thoughts.
So I mean, is it practical for us, at least at this stage, to say it would be collaborative in picking the sample for this pilot? But I mean, the important piece of it, Carrie, is that if this pilot works, we would want it to be replicated, right? We would, if they end up paying you $2,000 more a year for the consumers, because we're now reporting, we're doing this for them. I'm just throwing out a number. They give you a bonus of $2,000 who is included in this pilot, because that's how they save their money. Would something like this be replicable within an organization, or are we doing something that's all of a sudden going to it's totally non-replicable? Deb or Joan, do you guys want to chime in on this?
I mean, I'm kind of a numbers person. I mean, we would probably have to show them that they're getting value added
Yeah.
very clearly. I don't think we've done that yet. 80,000 feet, like an aerial view. If I were on the other side, I would say, I mean, show me a little bit more data, a little peel the onion, one more layer to avoid, so that I could really see clearly that this is a win-win.
The other part that I'm concerned about and is that we can report it to the SC, but it doesn't mean that it's going to go anywhere. We've been really struggling with service coordination to get information any further. Internal and external, that's across the board with managed care organizations right now.
I agree with you, Carrie, on that one. And that's one of the reasons why I want to stay with collaborative SCs, because I was hoping that SC agency would have like 2 or 3 SCs that we can focus on and train for working with us on this pilot, rather than hoping, and basically say that an essential element for success is being able to have SC collaboration, because
And
without it, I don't think it would work.
Right, and then what would be the expectation of the SC once we report this information that so-and-so is, not eating their diet, aren't taking their insulin properly, so we report it to the SC. Then it would be on the SC to do something to actually prevent the hospitalization.
Well, or to initiate a process that would give us the nurse intervention, or that would help with the actual avoidance of the next level of care that to kick in.
So it's really about it's really about minimizing the risk itself, like whatever.
Correct.
We need to remove the risk. We can't really prevent it, but we
this is This
the
is
actions
more
to
like,
minimize
this is
the
more
risk.
like a seat belt than it is
Right,
a.
right. I
and-
mean, I think it's we want to showcase that we're going to do what we can to minimize risk.
Right,
Thereby, you're hoping to reduce hospitalization, but the actual, what you're tracking
Exactly.
is, that's where they're getting the value. Like, we're
right.
reducing
You're
the risk.
reducing the,
It's
you're
a game,
spot
right?
on.
It's just the reducing the risk.
Reducing the risk of further higher levels of care.
Right, right. That's where they're getting their value added, that by just just the more risks that are minimized, you would think that there'd be less hospitalizations just by
Right.
removing those obstacles. The carpet that's, you know, damaged when they walk through to prevent a slip or a fall.
Mm.
Was just stated, someone's not eating, or, you know, there's bruises and they need a reminder, a medication reminder, or an appointment with the doctor. So I think we don't want to over promise and under deliver. It's basically reducing the risk.
Okay.
And we could quantify that with the strategies that we're employing, and we talked about the trainings and so forth, because they're
Right.
going to have some quantifying measure of that outcome. And so, yeah, I like that way better than just prevention.
We don't want to promise prevention. We can promise the minimizing of the risks.
Yeah, intervention as opposed to prevention.
Right.
Right.
I think that's better stated. Thanks, team. Thanks, team.
Minimize the risk. I like that. That's why I thought we needed to have this session today as opposed to next week. So could we add, I'll redo all this piece and recirculate it to you guys, but could we add, assuming they work with us to do this, we can develop a process that would truly bring together the training, the reporting, the SC cord portion of it, so that we can actually demonstrate that we have a process that would hate up for these risks, reducing the risks. Would you guys, I don't think the process, they're going to be, some of them are going to be unique to your agencies, but because of the way you do things, but we can develop an overarching process that would be applicable to this to this objective. Yes, that we can all agree on at some point and say, I'm going to customize it for my agency from this point on. Like whether, if we give you the training, would be decide whether you do it on Tuesdays or telephonically or in person and so on. You could customize it to the way you execute the process, but that the general steps in the process would be the same. Generally, yes.
I would say generally, yes. Generally, yes, just based on saying we could lay down a process. Of course, it's when we start to lay down the process that we can definitively say, yes, this will work for all of us.
Right. Okay, so, and at some point, this is gonna cost us more. And there's an RCPSO cost associated with it. So we need to be reimbursed for it. As we put together, if they say take it to the next stage, would we be able to quantify costs associated with doing this? I know I can do it for the RCPSO side, but within your agencies, would you be able to say, well, in order for me to do this, I need an extra $1 an hour for every consumer, or I need an extra X $1,000 a year more in order to do this? You think you can quantify realistically?
Yeah, I think we can do that. I think some of the areas that we would have to take particular attention to is the training.
Mhm.
How many attendants will be involved, how many hours of training,
Yep,
knowledge, and use, so,
reporting tools,
right,
those kind of things. And I'm thinking that this is going to be, when you consider potentially saving 5 hours a week of additional PAS of $100 a week, incremental PAS, they would, if they save that, it would be worth $5,000 for every one of these consumers, right? If they only save 5 hours a week, it'd be $5,000 a year. So I get thinking the way they pay for it is by cost avoidance, but it needs to cost them something that they pay you and RCPSO in order to make this happen.
Patty, can we step back a second to your last, to not the process, the one before that? When you're talking about providing HEDIS data. Now, I know I've heard about HEDIS before, but can you again?
HEDIS has nine key indicators that range from confirming that a woman has had her mammogram exam to reporting on the diabetes, on the glucose measures for a person who's diabetic. There are 9 such measures, and we would provide a training tool that would allow us to gather that data either in person or remotely. And a lot of the HEDIS data is now being gathered remotely, but somebody has to be there to measure the heart rate and measure the glucose measurements.
Right, would that be something, can you send us an email
Sure.
after this that lists those 9 things out? Because
Absolutely.
I think that is one we may be able to do to save them money, but
Mhm.
also that's going to be for some of them where it's going to cost us money to be able to provide those measures to them.
Okay, we'll do that. We'll give you I'll give you both the what they are and how they're gathered. So, because the reason HEDIS measures are so important to plans is this is part of the way they report.
Absolutely.
So we know that it's important to them and that they struggle to gather it from a lot of the community-based consumers because they don't have access to their physical health data as readily.
Right. And sometimes we don't either. And perhaps we can look at, once we see those 9 measures, instead of saying, giving them all their HEDIS data, that maybe we can focus on a few of those that are realistic for a home care agency to be able to collect, whether it's,
Fair enough.
did you have your annual PCP visit?
Yeah.
That's something that we can realistically collect that information. And if they haven't, then we can start that intervention phase of encouraging them to do so and schedule and talk to the
Or for a
SC.
man to go get his colonoscopy or.
Right. Speak
Okay.
with the SC, let them know this is the information we received from the consumer yet, but we would also need to know potentially from the MCO, since we don't have access to the medical data, when are they due for their annual visit?
I think that's fine. We can do that. And Joan, didn't you talk about this in our presentation yesterday? the data that you shared a document about HEDIS and CAPS that covered this topic pretty. So we can circulate that document. Is that public enough, or did we pull it specifically for that group?
I have to think back what source I used for that. I think some of it came right out of the CHC contract.
Right.
And there's some language in there that they call Pennsylvania performance measures. For example, they added asking if you've had your flu shot.
Mm.
So there, some of it's not spelled out.
Okay, so, but can I circulate the document that you shared yesterday?
Mhm.
Okay,
Yeah.
all right. I'll get that to Tiana to get it to everybody. So you'll have the HEDIS measures. You guys have I'm looking at the clock, and I know some of you have 4 o'clocks that you're gonna leave me for. But if we'll circulate the HEDIS data, we will information. We will I will update this conversation, the slides for this conversation with the input, which I thought, by the way, I really appreciate it. You guys did a great job in helping me focus it and making it so that we have a meeting scheduled next Wednesday, correct, Tiana? Are we?
Let me look, Patty.
I'm opening it up. No, we do not. We do not. So can we put a time on the calendar, or do we want to even have a live conversation before the 22nd? I can circulate a proposal for the discussion with PHW to you guys for input by probably Monday. To feedback on. Does that make sense?
Yep, that would be helpful.
Okay.
Again, we just want to make sure that we're not over promising on things that, you know, we are going to need more manpower
Sure.
to do, or if it's, you know, something that doesn't align with what we can expect our direct care workers to
Okay.
report back to us.
That's
and I
very
think a
fair.
lot of that, just because I'm trying to, like you said, think of some of them, and it will help to see them listed out. And we can make calls and ask about that. That's no problem.
Right.
And then and feed that into the service coordination entity. But then if PHW is going to come back and say, well, then what did you do with it after you got the information? Because they still didn't go and do this, then, and hold us accountable. Well, not for it. That's not really within the scope of home care.
Fair enough. Okay. Well, you make it easy. That's all. You ask the right questions. So, Deb, I'll also look for a way to bake in your thoughts, your ideas about credentialing without making it become a go, no go as part of this pilot. Because,
Okay, thank you.
and we will bring it back to the larger group for RCPSO to really make a determination of, you know, how important is it for an RCPSO owner to be credentialed in order to participate in the contracting. And, you know, like we did that for service coordination, as you know, Deb, with your sister agency, where we said in order to contract an NCQA accreditation.
Right.
So on the path is one thing that just means you started. It doesn't mean you have to have it. It could be a year and a half away, but it's also not an easy endeavor. It's a priority for an agency, and I hear what Carrie said. So, all right, folks, anything else you want to add to the conversation today? Look for something. By the way, for those, I'm remiss, I should have said it when we started. Tiana is taking on a larger role with RCPSO, and we're moving forward in a number of paths to create a little bit more distance between RCPA and RCPSO, because in some situations we have to work on contracting matters rather than advocacy. And so you're gonna name that will be coming out. We're changing our name to Prevent-A-Care. The board approved that just a couple of weeks ago. And Tiana is gonna be taking on a more significant role with this with Prevent-A-Care. So you'll see her on a lot more of these meetings, and she'll be the one doing a lot of the heavy lifting, I hope. So, all right, guys, have a good one. Have a good weekend if I don't talk to you before the weekend.